Okay, I will need somebody to evaluate today with their arms and legs accessible. I need somebody with their arms and legs accessible. Can somebody in shorts, please? Adrian? All right, have a seat. Okay, so we're going to move into muscle testing of the lower extremities today. Going forward, anything that involves the arms and legs in terms of muscle testing and sensitivity, it needs to be skin on skin. Right, so you need to make sure that you either have a gown available and make sure that you have those necessary equipment in order to have a good solid examination. You definitely can't do a sensation testing through any portion of clothes. So are you okay with something like this? Yeah. Yes. So we did yesterday. I noticed some problems with the West speakers, so it was a little bit muffled. I put in a request to IT this morning, and I'm still waiting for a response. Yeah. Can everybody hear me in the West? In the East, it still sounds pretty good. Okay. So I apologize for that. I also apologize for the leak, which also I had no fault of. So we'll just kind of have to do the best we can here. Muscle groups associated with the L1 and L2 spinal nerve root is going to be the hip flexors. Complaints on the left. We're going to start on the right. How you doing, Adrian? I'm Dr. Baudet, and we're checking some muscles in your legs. So what I would like you to do is place on the left. We're going to start on the right. What I'm going to have you do is try and bring your knee up to your chest. Just a second. Try and bring your knee up to your chest against my pressure. Is that painful? Want to do it just bilaterally and start with the uninvolved side first at all times. Resisted hip flexion, patient seated. Does he have to be seated? Could be supine. Standing might be a little awkward. And prone's impossible. I was about to say, is this thing on, but I guess it isn't. Well, Dr. Smith thought it was funny. Want to do our test bilaterally, start with the uninvolved side first at all times. Resist the hip flexion, patient seated. In this case, what I'm going to do is instruct the patient to put their knee up to their chest, and you resist that motion. Hold for 5 seconds. Any pain? Okay, that was no pain, and there was, so for those of you that can't really hear too well, thanks for coming forward, but I am recording this so you can go and revisit this because it's going to be very, very high quality going forward. So there was no pain, and there was, as far as I could tell, full strength to the level of 5 out of 5 on the muscle grading scales. It's negative or positive? The answer is negative. So what would an abnormal finding be? Reproduction of pain or marked weakness to the tune of less than 5 out of 5 on a muscle grading scale, and that could be indicative of what? Let's say there was painless weakness on his left to the tune of 4 out of 5 on the muscle grading scale, and normal strength 5 out of 5 on his right. What could that mean? So it is muscle weakness. So what is the indication? Yeah, so these are all abnormal findings. So what's the indication? So it could be either an L1 or an L2 radiculopathy on the left. Next question, how do you know whether it's L1 or L2 radiculopathies? Yeah, I understand all that. How, based on this test alone, how would you know whether it's L1 or an L2 radiculopathy? Based on this test alone, you would not. But what else would be present that's different in the case of an L1 versus an L2 radiculopathy? Would you do a dermatome test? And the answer is yes, I would, and that would be the difference. Area of hyposensitivity for an L1 radiculopathy is going to be just a little bit inferior to the inguinal ligament. The area of hyposensitivity on the L2 dermatome is going to be a little bit inferior to that, going lateral to medial and superior to inferior. The area of hyposensitivity, if they have hyposensitivity, will tell you which nerve root is affected. Does that make sense? See, you could have MRI vision. You could tell a neurosurgeon that, yeah, well, I suspect there's a 5 millimeter disc bulge affecting the L2 spinal nerve root on the left. Sure enough. If you don't have X-ray vision but MRI vision, guess what? That's good for business. And Shaq O'Neal went on record and say that his chiropractor can diagnose him without just looking at him. More specifically, he said, "You're my chiropractor, the diagnose me just without looking at me, bro." Make sense? All right. So muscle groups associated with, can I borrow a stool? Thanks, Kimberly. I mean, Holly. Holly. Muscle groups associated with the L3 myotome. Any questions before I go on? So the question was, if I see muscle weakness on the left compared to the right, am I immediately going to the dermatome test? The answer is I'll probably finish all the muscle tests, but I will follow up with hyposensitivity next. Make sense? Muscle groups associated with the L3 myotome is what? All right, so knee extension resisted. So Adrian, what I'm going to have you do is try and straighten out your knee against my pressure. Any pain with that? Want to do every test bilaterally and start with the unvolved side first at all times. A resisted knee extension, patient seated. You're going to instruct the patient to straighten out their leg and you apply resistance. Pain with that? Question? So the question was, would you rather put your hand closer to the ankle in order to provide a little bit more leverage? And the answer is that's not necessary in this case. We're just trying to match their strength. Good question. Any others? So the question is, would you have the patient kind of go through the action of the muscle function before testing and before resisting that motion? And the answer is, if you accurately wanted to grade the muscle using the grading scale, you definitely would. And the reason being is a grade of 3 means full range of motion, but no resistance. A grade of 4 means full range of motion against gravity and some resistance. 9 times out of 10, in fact, I'm going to go even further and say maybe 19 out of 20 times, if there is neurological weakness, it's going to be 4 out of 5. Rarely is it going to be lower than that. If it is, that's going to be pretty serious pathology. I think in the years I was in practice, I think I maybe documented a 2 or a 3 on a muscle grading scale maybe 5 times. 4, thousands. Make sense? So Usman was asking about resting tremors. And the answer is you would grade that. If you're seeing tremors, you would still assess strength and compare bilaterally. And it's doing this crazy thing with the matrix again. Yeah, you can't see it. Since he brought it up, if you do see a resting tremor, what disease do you think you'd probably have? So remember, in Parkinsonian, the tremor's at rest. If if they contract the muscle and you resist it, most likely the tremor will go away. Make sense? So you would just assess strength normally, just like you normally would. Okay, any questions on the L3 myotome? So positive finding is going to be painless weakness on one side compared to the other. So it could be damage to the L3 spinal nerve root, or it could be damage to the, I believe it's the femoral nerve, which innervates the quadriceps. Is that correct? So how would you know whether it's a femoral neuropathy or an L3 radiculopathy? Okay, so there's going to be a difference in terms of the hyposensitivity, different areas specifically, that's true. But on this test alone, coupled with the history, you should have a pretty good idea. Was there an injury to the low back causing a possible disc herniation, causing irritation to the spinal nerve there? Or was there an injury to the front of the leg? The history has to follow up. Any questions about that? Would you mind taking off your shoes? I'm gonna lower this. Muscle groups associated with the L4 myotome are going to be what? Ankle dorsiflexion and inversion. Points on the left and the start on the right. Adrian, what I'm going to do is I'm going to have you bring your leg, or bring your ankle up. I'm going to try and press it down. Don't let me. Okay, with that, want to do every S bilaterally. Start with the underbelly side twist at all times. Ankle dorsiflexion. Patient seated, or I guess standing, leaning. You're going to instruct the patient to dorsiflex their ankle, and you're just simply going to resist that motion. This is a neurological test, so you need to hold for 5 seconds. Painful. Okay, no pain and full strength. It's a positive negative test. Question? Because I'm going to check inversion next. So the question was, I'm not doing inversion at the same time. The answer is no. Why is that important? Bless you. So the answer is yes, that's correct. Patient, we want to start with dorsiflexion, but basically we're checking different muscle groups. So that's going to be important. Now, if the patient can't invert, and some may be a little bit uncoordinated, that's when you would check them together. And I found that for plantar flexion and eversion, you have to do it that way. And it's not because you shouldn't separate them. You should if you can. But I found that patients can't do that motion, eversion. So that's why I combine those normally. Probably need to do an inversion before everybody yells at me. All right, what I'm gonna have you do, Usman, is try and turn your head, turn your ankle like this, and I'm gonna resist that. Ankle. Other, no pain. Okay. Other side, inversion, patient seated. You're going to instruct the patient to turn inward. And I would caution you to say, oh, okay, patient, would you please invert for me? I'll probably turn their heads over heels. Inversion. Turn your left foot in for me, please. I'm interested. Ankle. All right, so both muscle groups were graded 5 out of 5 bilaterally, no pain. This is a negative test. Positive finding will be weakness to the tune of less than 5 out of 5 on the muscle rating scale, and that could be indicative of if both dorsiflexion and inversion was weak on, let's say, the left side, that would be consistent with an L4 radiculopathy on the left side. So the question was, what if a person has an injury to the ankle that might be causing weakness? And the answer is, if it's painful weakness and the patient discloses a prior injury, then no, that's not neurological. And I would not expect there to be a difference in hyposensitivity or the patellar knee-jerk reflex as I would for a neurological damage to the L4 spinal nerve root. Does that answer your question? Any other questions? Say what? Well, let me ask you this. Might there be a scenario where there might be deep weakness on dorsiflexion, let's say on the left, but inversion was fine? So the answer is yes, that's possible. So how would you explain that? Okay. So first thing I would be thinking of is, number one, is it painful? And then number two, I would think there was probably some direct injury, musculoskeletal rather than neurological, to the, in this case, the tibialis anterior muscle. Maybe if it's a child, they probably have Osgood Schlatter's, or what they used to call shin splints, things like that. Have you covered the adolescent disease where there's sort of an increased kyphosis in the thoracic spine? What's that called? Well, yeah. So the condition results in a over kyphotic thoracic spine. Does anybody remember the? Maybe you haven't learned this yet. Begins with an S. No. I thought I heard it over here. Yes, it's. But you haven't heard it yet. It's called the Scheuermann's disease, and that's when I would say you Scheuermann. All right, let's just finish this. I'm tired. Muscle groups associated with the L5 myotome are which? All right, so we have the hip abductors, we have the great toe extensors, and we have the little toe extensors. Extensor hallucis longus, extensor digitorum, longus and brevis. Place on the left, we're going to start on the right. Adrian, do you mind taking off your socks? Place on the left, we're going to start on the right. So what I'm going to do is I'm going to have you raise your great toe up, and I'm going to press it down. Don't let me. Hurt. Other side. Hurt. Now, these four toes, raise them up. I'm going to press them down. Hurt. Other side. Hurt. On your side, face. Let's see. Yeah, let's check. Yeah, on your side, face this way. Comfortable? So watch me for a second. What I'm going to have you do is raise your leg up like this, and I'm going to resist that motion. Hurt? Okay, flip over and face me. Same thing on the left. Go ahead. Does that hurt? Okay, you can relax. See this one. So that was full strength, 5 out of 5 bilaterally on all muscle groups. It's a negative test. Positive finding will be weakness associated with either extensor hallucis longus, extensor digitorum, longus and brevis, as well as gluteus medius. If they're all weak on one side to the tune of less than 5 out of 5 on the muscle grading scale, and everything was 5 out of 5 on the opposite side, let's say the left was weak, the right was fine, that's indicative of what? An L5 radiculopathy on the left. Let me ask you this. What is a common mechanism of a lumbar disc herniation? How do they happen? Where you try to lift something in bad posture. Okay, first name. Mohammed, you already told me that. Explain more about that. What kind of posture? What are you lifting? So how do you pop your low back? Well, let's say you're moving and you got a big heavy box of books and you bend down, you don't bend your knees, you bend at the waist, you pick up that book, pick up those books and you rotate to put it on the truck. Ow. So that something like that would have had to happen for you to diagnose an L5 radiculopathy, particularly if it's somebody that's not elderly. If it's non-traumatic and elderly, then most likely it's what? Most likely it's going to be irritation to the spinal nerve due to spondylitic changes in the lumbar spine, particularly intervertebral foraminal stenosis. How do you verify that? X-ray. That's correct. Which view? Oh shit, that's incorrect. So which lumbar view can you visualize this foramen? The answer is the lumbar. I mean, excuse me, the lateral lumbar. What about the obliques in the lumbar? What do you visualize? So basically, you're visualizing the pars interarticularis and the pedicles and the lamina, basically the eyes and ears and legs of the Scotty dog. Huh? Well, a to P lumbar definitely was part of the series, as well as a L5S1 spot shot. Make sense? All right, real quick, muscle groups associated. Well, let me work up to it. So suppose, listen very carefully. Suppose the left-sided glute med was weak and everything else was fine. How do you explain that? Radiculopathy, incorrect. Here's the scenario again. Suppose only the left hip abductors, gluteus medius, is weak and everything else you check, including the toes, are fine. What's the problem? What nerve? Superior gluteal neuropathy, I would be thinking based on this test alone, on the left. So my next question, how would that happen? Trauma, where? To the hip. Usually neuropathies happen by direct compression where they're most superficial. So something like that had to happen in terms of an injury. It always has to go back to the history. It doesn't make sense for you to say, oh, the person has an L5 when there was no problem with their back and all the injuries were in their legs. And you'd be surprised how many times I've seen that. I mean, seen people say that. Any questions about that? All right, real quick, muscle groups associated with the S1 myotome are which? Basically gastrocnemius, as well as the everters of the ankle, basically fibularis longus and brevis. Points on the left and start on the right. Adrian, what I'm going to have you do is, first of all, I'm going to have you. Now I'm going to try and evaluate these separately, and then I'm going to evaluate them together like I normally do. Everybody clear on that? All right. So first thing, with your right, just kind of press down like a gas pedal, and I'm going to prevent that. Painful. Other side. Painful. Now, best you can, try and turn your ankle out like this. And I'm going to prevent that. Painful. Other side with the left leg, go out. Painful. Okay, no pain and full strength. If I were to check them both simultaneously, here's how I would do it. With the right leg, I'm going to try and press your foot up and in, and you're going to come down and out. You pain with that? Okay, so now for the left leg, again, I'm going to press up and in, you're going to go down and out. Painful. Okay, so that was symmetrical, full strength, no pain, negative test. What are the benefits of checking those muscle groups separately? And there are some. So the peripheral nerve that innervates the gastrocnemius is a different one than what innervates the fibularis longus and brevis. What nerve innervates the fibularis longus and brevis? So deep fibular, excuse me, superficial fibular. Superficial fibular. So in the case of a neuropathy associated with that nerve, only the everters will be weak and the gastrocnemius will be strong. Correct? Now, in the case of an S1 radiculopathy or herniation at the lumbosacral junction, that's going to cause both muscle groups to be weak. See the pattern? And it also has to correlate with the history. Was there an injury to where the back meets the sacrum? Or was there an injury to the leg? Mm-hmm. Any questions? Everybody okay? Pretty straightforward. We are about break time. Let me verify that. Okay, so now would be a good time. Let's take about 13 minutes, and then we're going to come back and run through these one more time, and then we'll get into hyposensitivity testing. Thanks a lot. Okay, let's resume. So before we get into the demonstration, and I will need somebody again with their arms accessible for the next one. So before we begin, I just want to relate to you that it wasn't really relatively long ago that I was in your shoes and I was in professional school. So I know how tempting it is to do what I used to call triage, which is using other class time to study other classes. I know how tempting it is, but trust me on this. If you find yourself doing this, it's a downward spiral because you think you're catching up in one, but you're missing out on the task at hand. So please, please, please try and resist the temptation to do that. Does that make sense? Okay. Now, before we get to upper extremity sensation testing, I got lost up in the excitement of the first hour and I neglected to assess two muscle groups. Dr. Torrey mean you. Dr. Torrey doesn't approve. No, they weren't, but thank you. All right, so what other muscle group associated with the S1 myotome is going to be the hip extensors. Let me get you some paper. Can you lay it on your stomach for my first name? Brian. One more time. What is it?
Brian.
Brian. Okay. Complaints on the left. We're going to start on the right. Okay. Look at me for a second. What I'm going to do is I'm going to put my hand on your right thigh. And what I'd like you to do is with your knee bent, just try and bring your thigh off the table. We'll start on the right first. If it's a test that needs to be done bilaterally, then you want to check the uninvolved side first. And the reason being is we want to get a sense on what the person's better leg, in this case, is in terms of their strength before we move to the less than stellar leg, if that makes any sense. So knee bent, Now I'm gonna put my hand right here. I want you to try and bring your right thigh off the table. Bless you. Hold for 5 seconds. Any pain with that? Okay. I want to do abdominal chest bilaterally, starting on the bottom. First of all times, hip extension, patient prone. You're going to instruct them to bring their thigh off the table, and you match their resistance. Hold for 5 seconds. Any pain? Relax. So in the case of, in fact, you can sit and face the camera. So in the case of an S1 radiculopathy on the left, which muscles will be weak in your prediction? Let me ask the question again. If the diagnosis is left-sided S1 radiculopathy, which muscles would you expect to be weak in a textbook clinical scenario? I would expect, in this case on the left, I would expect the left-sided hip extensors, the left-sided ankle everters, the left-sided plantar flexors, all to be weak. Let me repeat, I would expect the hip extensors on the left, the ankle everters on the left, and the ankle plantar flexors on the left, all to be weak, and the right to be fine. Everybody got that? Let me get you some more paper. Go back face down if you don't mind. We're going to associate the muscle groups associated with the S2 myotome as the knee flexors. Points on the left, we're going to start on the right. What I'm going to have you do is put your leg in this position. I'm going to try and straighten out your leg. Don't let me. Painful? Want to do every chest bilaterally and start with on the ball step first at all times. S2 myotome patient prone. Do they have to be prone? The answer is no. What other alternatives do we have? Okay, so you can have him seated and basically pull. In fact, I probably should have done that because he was seated. You don't want to have the patient flip-flopping around like a fish out of water, particularly if they're in a lot of pain. Make sense? I'm not doing any more push-ups. Ready? Pain with that. Okay, now you can relax. So, positive finding, muscle grade less than 5 out of 5 on one side compared to the other, indicative of either an S2 radiculopathy, in this case on the left, or damage to the what nerve innervates the knee flexors? Sciatic. So this, so if somebody has weakness there and there was in fact damage to the back of the leg and not the sacrum, then if that person says they have sciatica, in that case, they're right. You know, you have no, you should be surprised how many people out there think they have sciatica when they don't. Does that make sense? What do they have? Well, not sciatica, particularly if the pain, numbness, and tingling is in the front of the leg rather than the back. Anybody else got a problem? No. All right, you can sit. Thanks. All right, so I neglected to do those last two, but I do want you to include those. I want you to include the hip extensors for S1 myotome, and we're also going to do the S2 myotome, which is the knee flexors. Everybody got that? All right, now let's move on to hyposensitivity on the arms. I'm Dr. Beaudet. I'm going to be checking some sensation in your on this part of your neck, your shoulders, and your arms. So what I would like you to do is, well, first of all, this is what you're going to feel. You feel that? So what I would like you to do is keep your eyes closed. Planes on the left, we're going to start on the right. What I'd like you to do is keep your eyes closed. Would you mind taking off your watch? What I would like you to do is keep your eyes closed, put your hands in this position. And what I would like you to do is, planes on the left, we're going to start on the right. What I would like you to do is tell me if there's any difference between this versus this. Any difference? No. How about this versus this? Any difference? How about this versus this? Any difference? Does this feel like this? Let me do this again. Does this feel like this?
Yeah.
Does this feel like this?
Yeah.
Could you flip your hand over? Does this feel like this?
Yeah.
Flip your hands back over for me. Does this feel like this?
Yeah.
I'm one of those up talkers. I hate them. Raise your arms up. No, not yeah, just like this. And does this feel like this?
Yeah.
Okay, put your arms down. So whenever I asked him, does this feel the same as this? He said, yes. When I asked him any difference between this versus this, he said, no. Is this negative or positive? The answer is negative. So what's positive test? Basically, positive test is marked areas of hyposensitivity on one side compared to the other. And the region and the distribution will confirm whether or not it's a spinal radiculopathy or a peripheral neuropathy. Make sense? So where is the C3 dermatome? Basically, depending on the reference, it's going to be where the neck meets the shoulder. C4 dermatome across the shoulder. C5 dermatome, lateral bicep, stopping at the elbow. C6 dermatome, lateral forearm to the thumb. C7 dermatome, middle of the forearm down through the third digit. C8 dermatome, medial forearm to the fifth digit. T1 dermatome, medial bicep. Right? So let's talk about proper pinwheel etiquette. So I want to demonstrate, you want to have the patient close their eyes. They could be completely numb if their eyes were open. That's a problem. And what I would like you to do is, you saw me clean it. You lay the pinwheel on and then you drag. This is not something that you want to wisp, and don't dig in there. If you're making red marks, you're probably pressing too hard. But lay the pinwheel on and drag, and whatever you do on one side needs to be completely symmetrical on the other. So while if I did, does this feel the same as this? While that might still be viable, I would advise against it. You want to make everything as uniform as possible. And you may alter the sensation if in fact, you really, all that should be making contact with the patient is the pinwheel. You shouldn't be touching them at all. And particularly if you have those steel ones. Anybody have the steel pinwheels, the Wartenbergs? You want to be very careful if you have those. Only thing I use those for is to cut lines. That was a joke, but also kind of serious. Any questions about that? Let me ask you this. Why did I ask him flip his hands over and I checked both sides of the third finger? Different innovations. Okay, tell me more. That's correct. I would just like specifics. Median neuropathy would cause hyposensitivity. Okay, so let's say there's a left-sided median neuropathy. Where would the hyposensitivity be? Only on the palmar side of the third digit. In case of a radial neuropathy, only the dorsal aspect of the third digit. What about a C7 radiculopathy? Both sides. So that's the why behind why we have the patient flip their hands over. Want me to tell you a story? This goes back many, many, many years. Actually, one of my very first trimesters being hired here. And anyway, and before I arrived on the scene, one of my former colleagues, actually a good friend of mine while I was here, He was a really nice guy, really, really good teacher, but a little bit laid back. Like, yeah, this is what you do. I don't know. And it was really just really prone to the students to just memorize a whole bunch of stuff. So I was evaluating a student that actually turned out to be the salutatorian of the class. And I was doing upper extremity dermatomes and did everything correct, bless you. And sure enough, he had the patient flip their hands over and check both sides and regurgitated abnormal findings and indications. And finally, I said, okay, that was good. Let me ask you a question. Why did you flip the hands over and check both sides of the third finger? And he looked at me like I was speaking Greek. I don't understand what you're asking, Dr. Burdett. Well, it's a simple question, name withheld. Why did you, what you did was correct, but why did you flip the hands over? That was correct. And he looked at me like, that wasn't on the script I memorized. See what I'm getting at? You wanna, if you have questions about why we do what we do, that's what we're here for as faculty. But I want you to understand the fundamentals rather than just rote memorization, just give me the points and let me move on. Because this is gonna be our bread and butter. We're gonna do this often. You're gonna be better than I ever was. Wow. All right, what's time? It's 11:30. All right, now I want everybody to pay attention. I'm going to do this procedure one more time, and I'm going to do it completely wrong. And I want you to watch me very carefully and see if you can pick up what I'm doing wrong and why it's wrong. Everybody understand? Okay. How you doing? I'm Dr. Burdett. I'm going to be checking some sensations in your, on this part of your neck, your shoulder, and your arms. This is what you're going to feel. Oh, let me, okay, I'm just going to continue. This is what you're going to feel. So what I would like you to do is keep your hands in this position. I'd like you to close your eyes. Plane's on the left, we're going to start on the right. C3. C4. C5. C6. C7. Flip your hands over. Also C7. You're welcome. C8. Just raise your hands up like this. Positive finding is hypersensitivity. You can put your hands down. Positive finding is hypersensitivity on one side compared to the other, and it could be a peripheral neuropathy or spinal radiculopathy, depending on the distribution of the loss. Give me my points. So as Sophie correctly stated, I'm wasting my own time and more importantly, the patient's time because, or Holly. So needless to say, we're dependent on the patient to inform us what they're feeling on this. So I would recommend saying in a variation of either does this feel the same as this or any difference between this versus this. Okay. And not only would I recommend it in order to get your habit of it, I would recommend saying it when you're shaving in the bathroom. Does this feel the same as this? Does this feel the same as this? Does this feel the same as this? Don't do that. If you have roommates, they'll think you're weird. Let me ask you this, and this is the last question I'm going to ask you before we depart. What if somebody was just hyposensitive on both sides or bilaterally? What would that look like on this test? So if somebody was bilaterally hyposensitive, let's say at the, which this is a hypothetical example that really probably won't happen, but let's just bear with me. If somebody was hyposensitive at the C5 dermatome bilaterally, what would they say if I asked them, does this feel the same as this? They would say one of two things. They would say, I don't feel anything, or yes. So if they say yes, that's technically a false negative. So you got to be aware of that too. And the same thing goes for generalized hypersensitivity. What would, say if they were hypersensitive in both sides, what would they say if I said, does this feel the same as this? They would say, does it, ow, stop that. Are you trying to kill me? Maybe. Any questions? All right, yeah. So the question was, if I already knew that they were hyposensitive on both C5 dermatomes, and I went ahead and did this test, then I just didn't get any information. You wouldn't, unless one of their main complaints was I'm losing feeling on both sides. Any other questions? We are maybe 5 minutes left, so I think that will give us time to maybe run through all of these maybe once, and then we can adjourn until Thursday.
Hypersensitivity be indicative of?
1 second.